The Curbsiders Teach podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions.
Furthermore, the views and statements expressed on this podcast are solely those of the speakers and should not be interpreted to reflect the official policy or position of any entity. You should always do your homework and give us any feedback.
Welcome back to the Curbsiders Teach Season 5, our series on health professions education. I'm Dr. Molly Hoyblein, joined by my co-host, Dr. Ira Krasnovskaya. And tonight's episode will discuss how to have effective feedback conversations in the moment on communication with our guests, Dr. Rene Claxton and Dr. Robert or Bob Arnold. Before we get started with that, Ira, will you remind the audience what we do on this show?
You got it, Molly. We are the Health Professions podcast for all things education. We use expert interviews to bring you teaching pearls and practice-changing knowledge to inspire the next generation of clinician educators. And we have such a great conversation with our guests, Drs. Claxton and Arnold. We talk about real-time communication feedback conversations. We share best practices, practical approaches, and there's really nowhere I'd rather be on your birthday eve, Molly.
Oh, thank you. But I think all of the listeners, you all will appreciate just how they really broke down very concrete tips to use with your learners, whether it's in the clinic, whether it's in the hospital, how to really support our learners to improve their communication skills and to look at communication almost the same way we would look at a surgical procedure or something similar, that there are steps that we need to teach our learners through and let them be able to be successful.
And one thing at a time. One thing at a time.
So to introduce our guests, we have Robert or Bob Arnold, MD, is the Gerald J. and Dorothy R. Friedman Chair in Palliative Care and Vice Chair for Professional Development in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Arnold is clinically active in palliative care. He has published on end-of-life care, hospice and palliative care, doctor-patient communication, and ethics education. He, along with Tony Black and James Tulsky, co-founded VitalTalk, the premier communication training organization for clinicians caring for patients with serious illness.
And we also have Rene Claxton, MD, MS, and she is a palliative care doctor and medical educator. Dr. Claxton sees patients at an academic hospital in Pittsburgh. She spends her non-clinical time teaching communication skills and training educators how to teach communication skills. Dr. Claxton recently completed a 2-year fellowship with Teach Like a Champion, which was transformative in the way she views teaching.
And we're excited to bring this season of Curbsiders Teach with the support of and in partnership with the Alliance for Academic Internal Medicine. A reminder that most episodes are available for CME credit through VCU Health CE for all health professionals at curbsiders.vcuhealth.org. And thank you to all of our Patreon members. If you love the Curbsiders family content and haven't joined, please consider supporting us and continuing to create this amazing resource. So without further ado, let's get to it. Very excited to have both of you on the show with us today. I'll start with you, Dr. Claxton. Is it okay if I call you Rene?
Of course.
Perfect. Thank you so much. I really appreciate you joining us today. And Dr. Arnold, are you okay if we call you Bob?
Yes.
Wonderful. Thank you. Well, we'd like to just have our listeners get to know you a little bit better. Rene, we'll start with you. Could you give us a one-liner to describe yourself and maybe include something from outside of medicine?
Sure. So I am, in no particular order, a string of adjectives would be introvert, mom, wife, palliative care doctor, lover of yoga, and person trying really hard to keep my houseplants alive and my orchid flowered after an entire year of being dormant. And that is the joy of the month.
That's amazing. I have never kept an orchid past its flowering time. I'm like, I'll just pass this on and go back to Trader Joe's and get another one.
Totally.
Oh my gosh. I did one time my intern year, a patient gave me an orchid and I was like, it's dead. It's never coming back. And then my second year, it came back. And I was like,
wow.
This is something, there's something, spiritual in that somewhere. But that's awesome.
It was a miracle.
Mm-hmm. Yes, exactly. Bob, can we come to you kind of for a one-liner to describe yourself?
Sure. I'm a clinician, educator, father, palliative care doctor, dog lover, listen to way too much music, and cursor.
Excellent. It's a good variety there. Any particular music that you've been listening to lately that you've been very excited about?
Oh, I listen to basically anything with English and words. So that's nothing in particular. But about
Okay.
500 songs a week. So a lot.
Wow.
Nice.
How do you keep track of that? Is that like a Spotify thing?
It's an Apple Music thing where I just listen to it once and I star the things I like.
Wow. Wow. And Renee, I'm sure that you also do 500 yoga poses
Oh,
a week.
definitely.
Yes.
From 3:30 a.m. to 4:30, I'm going through my yoga poses every morning.
You're like sun salutation for the 500th time. That's
I'm very
amazing.
limber.
Yes, yes. Well, maybe, one thing we like to ask folks is we're going to get into this a little bit, but in terms of thinking about things you've learned along the way and wondering, maybe, Renee, we can start with you, kind of what's your favorite failure and what did you learn from that?
Sure. So I feel like the need to start with the disclaimer that there are lots of failures to draw from. So of the many, the one that stands out and that's relevant to this one is the time that I contaminated an entire operating room as a MS3. So I followed diligently the instructions of get your gloves out and put them on the table. And I did that. And I neglected to think about which table and what else was on the table. And what was on the table was all the sterile instruments that we were going to use for surgery. And so the surgery was delayed and we had to re-autoclave all the instruments. And so what I have learned, in addition to that surgery attending's unending patience with me, because I was never yelled at and we just rolled forward, is that when things go sideways now with my learners, I take a beat and think about how clear were my instructions? What did I set expectations? Did the learner know where to put her gloves? And, I carry that an extra breath of patience with me.
Well, that's amazing because I think probably many of us who went into internal medicine have a similar memory. And for you to pivot it to something positive rather than I just remember the deep shame of having the scrub nurse yell at me for the 15th time. So,
yes, there was also the line of do not tie that knot like you tie your shoes.
No.
And I was like, yes, this is not going to be my home.
And Bob, what about you? Do you have a favorite failure that you'd feel comfortable sharing?
Other than the fact that I couldn't get my mic to work because I didn't turn the button correctly, that's my most recent failure, probably not my favorite failure. I think my favorite failure was or the one that sort of sticks is I was seeing an HIV positive patient and I told him that he had failed AZT and he told me in no uncertain terms that he took every blankety blank one of those medicines exactly like I told him to take it. And if anything failed, it was me, it wasn't him. And it sort of showed me the power of words and how they matter a lot, particularly to the people you're using them with.
Totally. I do some addiction medicine work, Bob, and we always talk about words mattering, like people living with certain conditions, kind of person first language. And I think sometimes we forget that even in our therapeutic conversations, we often miss those moments too. And we'll probably be talking about that a little bit more today.
Well, we are very excited to talk about communication and teaching communication skills on the fly today. So we'll start with a case from Kashlak. We have Ahmed. He's a fourth-year medical student that you're precepting in clinic. He's seeing Mr. Johnson, a 58-year-old man with poorly controlled diabetes who's coming in for worsening fatigue and frequent urination. You're in the room with Ahmed to observe him providing counseling to the patient about his recent labs. He starts the interview with a warm greeting and says, "Your hemoglobin A1C is elevated, indicating suboptimal glycemic control, which puts you at increased risk for microvascular complications." Mr. Johnson looks confused and responds hesitantly, "So my diabetes is bad? Should I be worried?" Ahmed continues without addressing his concern directly. He starts to ask Mr. Johnson about his medication adherence and presents some options around next steps for treatment. So I think we'll have a lot to talk about in this case of ways that an educator could help improve the communication skills here. But to take a step back, before we get into that, could you reflect on what made you passionate about studying and teaching communication? And Bob, we could start with you.
So I majored in philosophy, and my initial interest was in bioethics, and then I became a resident, and it was quite clear that ethical issues weren't the problem. People often knew what was morally correct to do. They just had no idea how to talk about it. And so I thought that if we were really going to try to promote communication skills, we really needed to try to do it in a way. If we were going to promote ethics, we need to do it in a way where we promoted communication skills. And then I got interested in palliative care, and a lot of what palliative care is trying to help people cope and negotiate. And so that was something I really was interested in doing.
I love the tie-in of the philosophy piece because I think sometimes we often forget about the power and the role that that plays in our communication and also our, it sounds like your kind of academic journey. I wonder, Rene, what kind of sparked your joy in studying and teaching communication?
I think studying communication, it was like as the resident, I was always the one to volunteer for the family meeting and never the procedure. I was like, who's going to put the central line? And I was like, not me, that's for sure. But who was going to run this family meeting? Oh, I'll do 100 of those. And so that feeling of fulfillment and that in this scenario just highlights so nicely those missed opportunities where the family's clearly baffled, the patient has no idea what we're talking, and we just plow on and give more information. You're like, wait. And just teaching people to recognize those moments first, take a pause, and then think about how we could be partnering better with our patients.
Totally. I think that partnership is huge. I think that's a big part of communication as well. And for Molly and me, I think feedback in general and communication is like super hot topic. We've had many episodes about this. Please see our first episode ever about it, as Curbsiders Teach, episode 1 with Calvin Zhao. And we know it's a hot topic for all health professions, educators. And we also know that with that comes a lot of challenge and unique challenges around feedback and kind of feedback conversations around communication. We can start with Rene. Maybe could you touch on, when it's specifically challenging, it might come up in like emotionally kind of charged situations and maybe how you respond to that, like what role that maybe the emotion plays in that?
Yeah. And specifically when you're talking about the learner's emotion or the patient family emotion.
I think both. I think we as educators would, love to hear more about, also for the learner and the person maybe observing it, but definitely for the patient too, because they're experiencing it firsthand.
Yeah. I think for a while we've tied communication skills to identity. And so you're good or you're not. And so people feel a lot more vulnerable when they're getting feedback on their communication skills because it feels real personal. And so one of the really helpful things is to set it up from the beginning that these are skills. Right? It's like riding a bike. It's something that you practice and you get better at with practice. It's not a good or not. And so if we set it up that way and the learner knows they're going to get feedback, and I'm also taking notes on what's going well and making sure that I'm telling them what they're doing well so they keep doing those awesome things. And then we talk about feedback in the looking forward, next time, or I wonder if in the future you might. It's so much more positive frame than you should have. And that often is a smoother way to give feedback.
I like that framing. And we've talked about feedback around professionalisms a few times on the podcast and kind of taking that same approach of you don't expect a first-year student to be able to listen to heart sounds and identify everything the same way you wouldn't expect a first-year student or even a first-year resident to feel totally comfortable communicating in a variety of situations. You mentioned kind of taking notes about the things that the learner is doing well. Is that if you were sitting in an encounter like this, would you be taking notes? How would you kind of keep your focus on the conversation and remember what you would want to give feedback on? And maybe Bob, we could go to you.
So before I do that, I want to have sympathy for Ahmad because Ahmad, like Rene, went into a conversation and had no prep. And so he talked the way he talks to his attending and his resident. And that's on me. That's my fault. I should never have let him go into that conversation without saying, I'm going to watch how you do this. Let's brainstorm to set you up for success. Because otherwise, you would never send a third-year medical student into surgery and say, just cut a little bit there, right? It's the same exact thing. The second point is that I think we do a disservice when we call it feedback, because I don't care what they did badly. What I care about is what they need to do it better. We should call it feed forward. And this is what Rene said. Instead of saying you need to use less jargon, what I should say is next time, I want you to try to explain what's wrong using language that a 9-year-old would know. We don't have to talk what you did wrong. All I need to do is focus on what you want to do next time. And I think that if you do that, learners get way less defensive because you're not critiquing what they did wrong. You're just showing them how to be better. This is not something, oh my God, I did all the negative stuff. We've learned that largely by watching K through 12 teachers who are the most positive and the most sort of encouraging of errors and helping people be better of anyone we've ever seen. And at least for me, it's completely changed the way that I try to help people be better.
Yeah, I think that language is really valuable to have sort of in your back pocket as an educator, to be able to think about framing things that way. And in terms of the K through 12 teachers, I assume you're talking about Teach Like a Champion and sort of the skills that you've gained from that.
Yeah, I think that one of the things that's really interesting for those of us who are medical educators, I never got taught how people learned and the cognitive science of how the brain learns, and most medical students don't either. That's why they listen to podcasts at triple speed. They have this fantasy that if they listen to it faster, it'll get in their brain faster, which makes no sense. And so I think for me, it was an amazing thing to talk to people who spent their time thinking about how people learn and tied teaching skills to the brain skills. And it's what we've also tried to do in our communication teaching and Vital Talk. And so it's just thinking about not whether I taught it, but whether they learned it. That's the key thing.
I love that, Bob. I also feel like we need a shout out to our previous episode on the science of learning, because I think everything that you're saying is really robust in that one. And also a shout out to a future episode, Rene, based on what you said about avoiding things like you should have, or Bob, what you said about feed forward as opposed to feedback. I think all of those kind of have an underpinning in them, like an anti-deficit approach, where you're actually thinking about like, what are the positives here? What are we learning from, and how can we continue doing the things that were working for us? So the things that are kind of strengths for us. And, to go back to the science of learning piece, and I think both of y'all have talked about this, written about this, taught about this. Do you all have any particular rubrics or checklists that might be helpful to the health professions educators, our audience, that might help them kind of free up any working memory during observations like with Ahmed, and kind of how you would suggest educators go about that?
Yeah, it's such a good question. I love that you're thinking about the teacher's cognitive load, because so important to really think about our learners' cognitive load, and then we kind of forget our own, and it is really hard to balance all those things. I think one of the things that might be helpful is you negotiate before you walk in the room which part of the interview the learner is going to do, right? So I don't have to watch for everything they're going to do. He said he wanted to give a headline. I'm going to watch for the headline so that I can give exact feedback on how that part went. And if I catch extra things, then great, but I'm going to really focus my attention on that. That helps my cognitive load.
We wrote an article in Academic Medicine, James Tulsky and Tony Bach and I and some others, which is basically, it's called Can I Add Something? And it basically is a mental model for how you can start doing what Rene said. You then walk in the room and gather data and decide whether you have to intervene or not. And rather than just interrupting, you say, can I add something? Because then the learner feels respected, as opposed to, oh my God, the attending's interrupting, I must have screwed up. And then there's a very structured way to debrief, which the advantage of it is the learners then expect it. Every time we walk out of a room, the learner knows they're going to hear the same 5 questions. and we're going to go through the same dance, which means they're not worrying. They know what's going to happen. We're going to walk away with one learning point because that's the most they can do. And we're going to go see the next patient. And it only takes us 3 minutes. That's the other thing. If you're a hospitalist and you're having conversations and you feel like you have to spend 20 minutes debriefing, everyone's head explodes. It needs to be quick. It needs to have one learning point, and you need to move on.
And could you outline what those 5 things that you're going through, those 5 steps that you're going through in that feedback conversation are?
Sure. First, you walk out and you say, "Ooh, how'd it go?" And what you're doing there is you're gauging the temperature of the room, right? Because if it was a really hard conversation, they'll need to emote. You'll need to attend to their emotions. Then you say, "Tell me something that you did well." Not something that went well, something that you did well, because I want them to continue to do it. And if often learners don't want to say something they did well, so it's my job to say, "I really liked how you did this, and this needs to be as specific and clear as possible." Then I say, "Looking back, is there anything that you weren't sure about?" Or if I intervened, I say, "Did you notice what was happening before I jumped in?" And we find a learning point that we can do a little bit of teaching about. And then we end by saying, "So based on this conversation, what are you going to try next time? What one thing are you going to try to be better at next time?" And then we move on. Rene, what'd I leave out?
You got it.
Okay.
And I think we've covered, and I think other authors use similar kind of approaches to feedback around other types of, if it's around clinical skills and other kinds of things. So I think educators probably have some familiarity with an approach like that. And I think being able to say, I'm used to doing this when I give clinical skills feedback, I can use the same thing to give communication feedback can be a really helpful approach. I think that's helpful to kind of have a very discrete part of the conversation that you're trying to give feedback. But there certainly are times where just something happens and that doesn't necessarily take place in advance, or you can't have that pre-brief in advance. How do you sort of focus in on what to give feedback to the learner around? Because there probably are many things that you're witnessing around the conversation and around the communication skills. How do you keep it focused enough if it's not something that the learner necessarily identified in that conversation that you're having? Bob, you look like you have a thought? Or
Yeah, the problem is I'll always have a thought. That
Okay.
isn't the question. Look, the goal of giving feedback is that the learner is ready to change. So I'll say, looking back, where were you curious, or where did you feel stuck, or is there something you weren't sure about? And if they name something that I think was something they could do better, I'll go with their choice over my choice because there's juice in it, right? They're like, "Ooh, I wasn't sure this was good." We can give them something that they can learn to do better. If there's something really big and they're like, "I don't remember," because remember, when they're in the room, their cognitive load is completely consumed by what they have to say. So they often don't see what the patient or the family did. I'll say, "Did you notice what was going on when you said X?" That is, I'll point them to the thing I want them to pay attention to. If they see it, great. If they don't, I have to describe it. I'll say what I saw was, because what my meta goal is that they begin to view communication as something which they need to pay careful attention to, and they need to gather the data in the same way that when you're an intern and you walk into the room, you have to gather the data about whether this patient is critically ill or not. Right? It's the exact same concept. I want them to view communication as emotional data, cognitive data, and begin to see more carefully what's going on.
Can I add one thing, Bob, which is, and just let me summarize first and make sure kind of Rene, you and Bob agree with the summary, but I'm hearing like the, how did it go? Tell me something you did well, or offer, I really like how you did this. And then maybe looking back, was there anything that you weren't sure about? choosing that learning point, and then based on the conversation, kind of one thing that you want to try out next time. My question to there is that, you added this part about like what was happening before I jumped in as a potential for, was there anything you weren't sure about? That jumping in point, if we can just zoom in on it, like the part where you're in the room and you say, could I add something, right? Molly and I have talked about this and how much time an approach like this could take. And my question to both of you all is kind of, one, how do you do that interruption in a way that kind of supports the learner, the could I add something phrasing? And two, that jumping in part also takes time separate from the kind of debrief. And so how do you really negotiate or manage your own cognitive load, your time about where you want to jump in or where you want to kind of share that teaching pearl? And I didn't mean to stun you all.
No. I'm just thinking about all the different factors that are playing in your mind at the same time as the faculty person. You're right. There is some real life constraints, right? It's like, how many more patients do I have to see today? How long is this meeting going on? How efficient is this learner? And, maybe the learner is going to get there, but they're learning it. It's going to take them twice as long as it might take me to get there. And that's part of learning, and that's fair. So if I can, I want to give them that opportunity. And also, if it's 5 p.m. and I've got 10 more patients, then today's not the day. And I might be more likely to intervene because neither of us are going to learn something if it's 9 p.m. and we're still seeing patients. So I think there are some thoughtful things going on in my head about why I might, in addition to the learning opportunities, when I might intervene. And then I'm transparent about them. Like, hey, it was going fine. I just thought we could get there a little bit faster. And so I intervene when we're outside the room. I might just be honest.
It's a lot like when you intervene when you're having the resident do an LP or put in a line, right? There's the exact same considerations. It might be that you figure they'll get it done, but you're too antsy, you're too anxious. And you just need to be honest when you get outside the room saying, I know you could have got there. I just I was too worried about time.
And the opposite is also true. I was definitely in a family meeting when one of our fellows, before we make a recommendation, we map. And so she was asking every mapping question that we had taught her, it was extensive. And we came out the room and she said, I noticed that you put your head back and closed your eyes. And I was like,
Oh, no.
Hey, you were doing a fine job. The patient was not distressed. She was having a lovely conversation with you. You were getting the data that you needed. Could we have done it in less questions? Sure. But we had the time. You got to practice. Fine.
I guess I want to make another comment, which is you need to be careful where you sit in the room. So I'm an old white man. If we sit on opposite sides, if the resident or fellow or student sits on one side of the bed and I sit on the other side of the bed, everyone is going to talk to me. So I make sure that I sit about half, this far behind the patient, behind the learner who's running the conversation, so that the patient can't look at me without looking at the learner, because I really want them to be talking to the learner. It also means that if I'm going to intervene, I can pull my seat up and sort of move forward and say, can I add something? And it signals to both the learner and the patient that I'm sort of now taking the strings.
Yeah, I think that positioning and setting the learner up to be, the learner is the clinician in this moment, and they are going to lead the interview for X portion or as much as possible, or the whole thing is a good way to give them autonomy. To wrap it back to our case with Ahmed, you've discussed how things went and given him kind of the recommendation that he can use more patient-friendly language next time, or speak at a lower level, avoid medical jargon. I guess we're trying not to say avoid, but to speak at what a 9-year-old, as you said, would understand. Are there some concrete next steps that you would take to support him in these goals moving forward?
Yeah, when we go see our next patient, I'm going to say, so Ahmed, remember last time you said you really want to work on using patient friendly, patient first language. So take 30 seconds and write down exactly what you're going to say to get this started, pretending that you're talking to a fourth grader. We're going to practice it before he goes in the room. I'm going to set him up for success. And then I'm going to say, all I need you to do is tell the patient how their blood sugar is doing and then hand the rest to me. Because his cognitive load is going to be so full of just doing that piece. If I ask him to do the next piece, there's a very high pretest probability it's going to fall apart. I want him to just have unmitigated success. And then the next time he can add another piece.
I think that practicing for success is so important, and just being able to work through it ahead of time on his own is a great technique. I think this is good for this case, unless anyone wanted to add anything else, and maybe we'll move on to the second case. Ira, do you want to kick us off?
Totally. Thanks, Polly. So this is Isla. She is a second-year resident that you are also precepting in clinic, and she lets you know that her next patient is coming in to review the results of a CT scan that was done to evaluate abdominal pain. That CT scan shows a pancreatic mass concerning for cancer. She's nervous to share these results with the patient and wants your help in planning how to approach the visit, which I think really nicely dovetails to what we were just talking about with kind of the brief or the pre-conversation. So I wonder, Rene and Bob, is there a framework that you could teach Isla around sharing bad news, or even maybe starting this conversation per se, and how you kind of set, again, the learner up for success and really the verbiage you might use? And maybe, Rene, I'll come to you first.
Sure. So the framework we use is ask, tell, ask. So starting with assessing the patient's understanding. And I'll coach them on, it seems easy when you just say, check the patient's understanding. And actually there's a lot of nuance in how we say that, right? With it, when it's, what do you understand the doctor's told you? Sounds a heck of a lot different than, I talked to the other doctors and fill me in on what they shared with you. There's a world of difference between those two. And so first step is asking the patient's understanding, and we'll walk through exactly what that looks like. Then another ask of asking permission. Is it okay to share some news? Which is kind of a stopgap. It makes sure that the right people are there. Like, oh, well, my surrogate's down there getting coffee. Well, why don't we just pause and wait? Or this is a crappy time because people have come and checked my blood and did all kinds of other tests to me and I don't want to put up with it. Fine. So asking permission. Then the tell is giving the news. And I think Bob alluded to this, giving a headline. So we think of giving our news in 1 to 2 big picture sentences with information and then also the meaning in terms of impact on the patient and the family. And then the second ask is checking in. Sometimes I'm not very clear in what I'm talking about or what I'm saying. I just want to make sure that when you tell your husband what we talked about, I did a good job. Can you share what you're going to tell them when you call them? Sometimes when it's serious news and everybody in the room starts crying, then I don't do a teach back because it was really clear that they heard the message. And then more time in that situation, it's more checking in on the emotion. Like, hey, was this even on your radar? Is this something you're expecting, or is this just a huge shock? Because that also is a gauge that tells me how much farther we're going to go in this conversation. If I just blindsided you with a bunch of news, then that's probably all we're going to do today, and that's totally fine. So that's the frame, the ask, tell, ask. And when I'm precepting learners, I'm thinking about one of those steps, not all of those steps. Like maybe a second half palliative care fellow is doing all those steps, but even then I'm trying to zero in on a part of it.
I like that, breaking it down. And do you kind of role play with the learner of, say out loud specifically how you would ask what you know about the results of your pancreatic scan?
100%, right? They don't know where to put the sterile gloves. Like, they're going to contaminate my OR.
Yeah.
I need to practice outside the room.
Yeah. Great.
And it helps, I'll say, for 2 reasons. It helps them practice, right? It helps them get their words. They feel less anxious. And I'm also less anxious because I know what they're going to say. And so I'm much more likely to give them space to get it out and not intervene because I know that they have prepped. So it helps both of us.
And Bob, could you kind of give us some tips around how you might help a learner who's ready to take on the headline, how they might frame that headline or prepare for it? What specific actions should be part of that? And
So again, if it's a novice learner, I say take 30 seconds, write down what your headline is, and I encourage them to write it down because I want to see what they have written down, and then I'll give them my headline, and then I'll say, go back to your headline, and is there anything that you would modify? And I'll say, it's okay that you walk in the room with it written down. Because if you don't have it written down, I promise you, because you know that it may hurt, they will be emotional, you will hedge. And so early learners should write their headline down. They should make sure their attending agrees with the headline. They should crowdsource it with the specialist so that everybody's on the same page. I think the other advantage of making people write it down is if you've been paying attention, if you've been watching the first 30 minutes of this, I am verbally very fluid. So when you ask a question, I will always have an answer right away. Rene is more thoughtful and reflects on the question. And so the point is, I want someone to give me their best headline, and giving them time to really think about it and to write it down means I'll get their best headline rather than the first thing that pops into their head. And I just think that's really important and something I wouldn't have done 5 years ago. I think saying take 30 seconds, write a shitty first draft, we'll figure it out so it's really good before you go in the room is really important.
One thing I was wondering was, Rene, to your point about I don't have people do all three ask, tell, asks, and kind of Bob, the practice of the headline. How do you all negotiate which of the three components a learner or a trainee may do, or kind of where you all come to an agreement around that decision making?
Say it's shared decision making. Learner, what do you want to work on today? And I also have a frame in my head. If this is an MS4, no matter what they want to work on, they're working on the beginning part. It's so great that you want to work on this part that's 5 steps at the end of the model. In order to do that, we have to do step 1. So let's work on step 1 today. And it also is helpful the more experience I have with a learner, right? If I've seen them do 5 family meetings, I have a sense of their skill level and if I need to push them or if they're on track, on target. And if I'm new working with somebody, I'm likely to have them start at the beginning and show me.
I think the metaphor of surgery is important. If you said to the third-year medical student, what do you want to do? And they're like, I want to cross-clamp the aorta. You'd say, well, why don't you practice closing, right? And so I know what's the harder part of the conversation. And if they don't even have a mental model yet of how to give serious news, all I want them to do is to practice the first ask. And then I'm going to say, watch how I give the headline. So they're going to practice something. We can give them feedback on it. And then they're going to watch how I do it. And then later in the week, we can have them practice the second part based on how they did the first part. It's very slow.
But I think giving them the tools to be able to be successful along the way is very important. And so it is slow. It takes moving step by step, as you're saying. If this resident is pretty advanced and she's feeling like she's ready to give the headline, she's written it down, maybe you've already seen her do a few of the asks in the past and you're feeling good about having her do the ask, give the headline, and she's pretty nervous that this news will be quite distressing to the patient. Can you talk us through any frameworks that you find helpful in teaching a learner how to respond to emotion in a way that's helpful to the patient and improves communication? Rene, we could start with you.
Sure. So as a Vital Talk teachers, we use the nurse mnemonic for responding to emotion using verbal empathy. So N is naming. So I'll go through and I'll give you an example of each of the. So N is naming. So looks like this is a big shock. Not what you imagined. So kind of naming what you're seeing in the room. U is understand, which typically is I can't imagine how it must feel to be hearing this, or I can't imagine what you're going through kind of statement. R is respect. So I think as doctors, we underestimate how hard it is to be a family member and a surrogate in the hospital. We complain about them when they're there and they have 10 questions, and then we complain about them when they're not there at the bedside. Like, they can't win as surrogates. And so reframing with a respect statement of like, you're doing an awesome job advocating for your mom. You have Googled all of the medicines on this list, right? Like, you stayed up all night because you love your mom, helps really bring down the emotional temperature. It also resets me. Instead of being annoyed, I can just frame as what's really important, which is this person is showing their love. So that's R. S is support. We'll be with you. We'll keep following. Here's how to get us. And then E is explore. So that is the classic, tell me more. Walk in the room and someone starts yelling at you. Outside hospital X told me blah, 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 and you're not blah, blah, blah. Oh, okay, tell me more. What else? It lets them come down a beat, gets you a lot of information. So that's the nurse mnemonic that we use for responding verbally with empathy.
And communication teaching is hard in a lot of ways because you don't know how the patient is going to respond. So, I mean, this feels like a lot to keep in an early learner's head if it's not something they're familiar with ahead of time. Do you try to say, like, today we're going to practice just the end, just the naming, but you may choose that and then go into the conversation, and really probably one of the other strategies might have been more effective. How do you sort of balance that in your teaching?
I guess I'm going to ask Bob, what is his thoughts on this?
So I don't typically say we're going to practice, or I'm going to say these are sort of things to keep in track. What counts as much is which word you use. It needs to be a word that feels genuine to you. I think that early learners will be so in their head and so trying to say the words that it'll sound fake and wooden. And rather than getting annoyed at them, I just view that as the learning curve of an early learner, right? And so at the beginning, I would say to this resident, I would say, you give the headline, and then I'll pick up and I want you to watch what I say to respond to the reaction that we get. And then we'll debrief it, and I'll say, what could you have said? And they'll have some practice. And then we'll go into a room and they'll try a little piece and we'll see how it lands. And remember, these things work in 75% of the cases, and 25% you're going to have to do something else, and we'll debrief it. And it takes a lot of swings at the bat. They need to do it a lot of times and begin to get, they need to get communication scenarios in their head about these kinds of things will work in these kinds of situations. In the same way that they have disease scripts, I think Rene and I are building communication scripts. And so I would never have them the first time give a headline and then have to attend to the emotion. It's just too much for them.
I do like the kind of the framing that it sounds like goes into all of this. And Molly knows that I'm like obsessed with role play or role practice, and we've done that a few times on the podcast. Don't worry, I'm not like volunteering myself as tribute for that. But I guess I might wonder, do you actually go through kind of the, nurse mnemonic and that approach and have a bit of a role practice with the learner? And the reason I ask this is because Molly knows I'm like obsessed with making sure there's enough time for things. And I worry that there's like not enough time for all of these amazing teaching pearls, and our audience members, may be strapped for some of this time. So I just wonder how you all make that decision and really prep the learner for success in this conversation.
My view is that I get 2 minutes before we walk in the room, and I get 2 minutes when we walk out of the room. So if again, they're practicing headlines, they have to write the headline, they'll watch what I do, we'll debrief it. But we can't spend more than 2 minutes before we go in the room. I'll lose them. I'll get anxious. because we have 7 other patients and we have 2 minutes. We only want one learning point. I'm a tremendous believer in you can only learn one thing at a time.
Totally agree. Don't worry, I'm learning more than 1 point here today, for sure.
On triple speed.
Yeah. Molly knows this, but I may or may not, Bob, be like case example that you were mentioning. Don't worry, not 3x, 1.7. So, or maybe 1.3. I reduced it recently. Yeah. Anyway.
I think these are all super helpful, and they all rely on direct observation, which I think makes sense because this is communication feedback and communication training. But are there other ways to teach communication besides direct feedback? I mean, sometimes it just feels so busy in a precepting session that you're with 3 different learners and the timing doesn't work out quite right, that you're actually able to be in the room for this particular encounter where they're trying to practice these skills. Is there any other approach, or we really just need to make the time to be in there and see it happen?
That's a yes and answer, right? Yes, we need to make time to be in the room. They need to practice with patience, right? That's, if we think of a sports analogy, we think of drills versus scrimmage. The patients are the scrimmage or the real game, right? You could argue that role play is the scrimmage, patients are the real game. And what we haven't done historically, and we're starting to do a lot more, is drills. And so here's a case. Everybody write down the headline. You've got 1 minute to write down the headline. Then we're going to share our headline with the group. Based on your colleagues' headlines, we're going to revise ours. So have a chance to go through that learning cycle and reflect, revise. And then it gets you more at bats, right? It gets you more practice creating headlines. And then you can apply it, the scrimmage or the real game.
I love that. I wonder, Rene, with these drills and maybe pre-scrimmages, do y'all ever kind of in even your communication script development, do y'all ever use like AI or other kind of technology tools to help you with this? Molly and I had an episode on AI with some AI leaders, and it just feels like the future is bright for kind of integrating that into health professions education. I wonder if that applies for you all in communication education.
I 100% agree that is going to. I personally have not integrated it. I know Bob's been playing around. I can defer to Bob on his experience up to now.
I think AI is a tool. I think we shouldn't lose sight of the cognitive learning process. And I'm not convinced that AI can give actionable feedback. So you could use AI to come up with lots of cases of very small pieces. I'm not sure that AI, from what I've seen so far, it can't give specific feedback and then have someone practice again. The thing I would say, because I think observation is key, is you don't need to be there for a 30-minute interaction. If you're in clinic, you can say, text me when you're going to do your education. We'll just watch. I'll come in just for the education piece, or I'll come in just for you setting your agenda. I only need 4 minutes because I promise you we're going to find one thing that you can do better in those 4 minutes. And that's all we're going to focus on anyway. To sit there for half an hour, nobody has time for that. And so I want to encourage people to be really parsimonious in their watching for one thing. Because when I was a preceptor in clinic, or when I precepted in clinic and my attending told me 7 things that I could do differently, I was, 1, just annoyed because I was now even later. And 2, I didn't know which of those 7 things had the highest yield. And I think that you only learn 1 brick at a road. You only build the road 1 brick at a time, 1 thing each time.
Amazing. Well, I think this has been great. Are there any other major things you think that we should dive into? Anything else that we need to wrap up about this case, or are we ready to go to take-home points?
I think the only thing I would say is that there's a fair amount of data that learning is social. And so I have no trouble debriefing in a small group. So we could have 3 people go in the room, and 1 person is the talker and 2 people are watching, and they have to tell the person in the room something they did well. And they are going to learn when we debrief that one thing that they could learn to do better. And you build a culture in which we're all going to get better every interaction. And I think the model is so positive that there isn't this sort of, oh my God, you can't tell me something that I could do better in front of other people. This is just the way we roll. And again, the analogy to sports is really true. Your coach never would pull you aside and say, let me talk to you about how to kick the soccer ball. Your coach tells you what to do next time in front of everybody, because everybody needs to know how to kick the soccer ball. And so I think our view is that you can use the social psychology of the group to help everyone get better, even in things like communication.
I like that. It feels very practical for teaching on rounds where you can't easily separate the group in and out, and really does allow for improved learning across the whole team. So I think that's great.
Well, should we do take-home points, Wally?
Let's do it.
Rene, Bob, major take-home points, if we haven't already said them, for our listeners, what would you like them to take away from this amazing episode?
I think my big takeaway is viewing communication skills as a procedure. And Bob already alluded to this, right? That you wouldn't send somebody to go and do an essential line all independence when they've never done it before. And so thinking about what do you need to do to set expectations up real early? How can you give them feedback in the moment? And then give them, progressive responsibility as they advance.
My big take home is that what I want learners to see is that if they act differently, their patients will act differently. And the parallel process to that is if I teach better, they will learn better. Medical students and residents and fellows are clearly smart enough. And so the challenge is when they're not learning what I want them to learn, the responsibility is my responsibility to think about how I can teach more effectively. And I think it's easy, particularly as you get older, to say, well, those medical students these days. And I just don't think that's true. I think the challenge is I need to think more carefully and give better directions so that they can succeed, because they clearly want to succeed.
Fantastic. Well, thank you both so much. We like to give all of our guests a chance to plug something that they're working on, a recent publication or an important resource. So if you have something that you'd like to share, and I assume many of our listeners are familiar with Vital Talk, but if any aren't and want to kind of learn more about communication skills and improving your communication with patients, especially around challenging news or serious illness, maybe you could give just a quick plug for that too, but you're welcome to talk about something else also. Bob, we could start with you.
So I was assigned to talk about Vital Talk.
Perfect.
I think, Vital Talk is a not-for-profit whose job is to ensure that every patient and family is surrounded by caregivers who can talk about what matters most. And it uses basically all of the sort of educational frame as well as talking maps for communication. There's a free Apple and Google app that focuses on how to give serious no's and how to talk about prognosis. If you're interested in being better at your communication skills, they teach both virtual and in-person courses. We now are developing some asynchronous material about how to talk about discrimination, how to talk about best case, worst case. And so we're really trying to expand our repertoire to help all clinicians, doctors, nurses, nurse practitioners develop these skills, because the problem is they seem like they're just talking and yet none of us learned how to do them. And they're a lot of what drives our satisfaction in taking care of seriously ill patients. And if you just go to vitaltalk.org, that's where you can see it all.
Rene, do you want to plug anything?
Sure. So Bob and I, for the last 2 years, have been fellows with Teach Like a Champion. So they are an organization of K through 12 teachers who are really focusing on teaching strategies that maximize engagement in the classroom. And so one of our deliverables was creating a virtual series for medical educators. So how to take the teach like a champion skills into the medical education arena, both in the clinical setting and the didactic setting. And that is coming up May and June. And so you can find that on the Teach Like a Champion website in their little search thing, just write medical educators, and you will come up with the series. And Bob and I are teaching, and we'd love to have more people because otherwise our feelings will be hurt and we'll be lonely. So, sign up and keep us company in the series this spring.
Very cool. Do you have a favorite technique?
Of course. So as Bob mentioned, as the slow thinking introvert, the idea of wait time has been transformative, right? The having some time to think before I have to give an answer and giving my learners time to think, time to perhaps even write before I call them for answers. It makes them more prepared. It makes them much more likely to be successful. And then I can call on them and invite them into the conversation and make sure that everyone's participating.
Fantastic. Well, thank you both so much. This has been really great. I think a lot of practical tips, and we really appreciate your time.
Sure. Thanks for having us.
Well, I would say the thing that I want to take home from this episode or back to clinic next time I'm in a situation where I'm trying to teach serious conversations or even just improving communication skills with a learner. I love the idea of having the learner write it down in advance. I think we often do that for like early learners who are working on their oral presentations. You almost sort of have them write their note to practice what that's going to look like. But I haven't actually used it in the sense of writing down what someone's going to say to the patient. And I think that really could give learners the space to think through it and practice it multiple times in advance. So I'm going to give that a try. What about you, Vera?
100%, Molly. I love that. I really like the approach that Bob shared. And I do, when I'm in an inpatient consult attending, I'll do the what went well? What did you want to do differently? And those are really the two questions. But I really liked kind of his framing of looking back, was there anything you weren't sure about or something you were curious about, and kind of opening up the space for the curiosity in the debrief, I think was really powerful. And I think that I love that he was like, this will take 3 minutes, because we've talked about the timing piece. I think it's really nice to just make sure that you're naming for patients, for learners, this is what we're going to do. These are the 5 steps. And specifically, was there anything you weren't sure about?
I love that too, because I think it takes, what I've previously been taught is to say what didn't go well or what do you wish you did better. But saying what were you uncertain about or what were you curious about moves us into that anti-deficit framework. So I love it. Well, this has been another episode of The Curbsiders Teach. Get your show notes at thecurbsiders.com/teach. A special thanks to the Alliance for Academic Internal Medicine for making this season possible, and to Dr. Karishma Patel for helping with our behind-the-scenes scripts and show notes. Thanks to Dr. Matt Watto and Dr. Paul Williams for their support in this project. Thanks to the team at Podpace for editing and production support. Until next time, I'm Dr. Molly Hoytline.
And we're committed to providing you with high-value, practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review this show on Apple Podcasts, or contact us at thecurbsidersteach@gmail.com. Reminder that this and most episodes are available for CME credit for all health professionals at curbsiders.vcuhealth.org. All you have to do is create an account, and I'm Ira Krzyzanowska, and thank you so much for joining us today and letting us bring you a little nugget of medical edutainment.